Good morning, Professor Varghese.
Good morning.
Good to talk to you this morning at the Safety 2024 conference. We have lots of questions for you, but in the interest of time, we'll keep it down to a few. Right now, we'd love to know what you think are the current challenges in post-care trauma.
Post-crash trauma care. So when a crash happens, most people want to believe that they are transported by an ambulance, they'll reach immediately to a hospital and they'll get care in a hospital which is state of the art. But the reality is far from that. If you look at the statistics of people transported by ambulances, then the numbers would be somewhere around 10, 11 maximum, varying from state to state, maybe 4% in some states, maybe 6% in some states. Even a city like Delhi, it doesn't exceed 10%, even today's time. So 90% of the injured in this part of the world are outside of ambulances, whereas more than 90% of injured are inside ambulances in high income countries. So should we want that they should all be in ambulances? So the question comes, what is happening to the 90%? Are they all dying? No, they all do not die. 50% that die, they die at the site because of the seriousness of injuries, and most of them, from the study that is done in the TRIP center, we find are either motorized two-wheelers, drivers, or they are pedestrians, or they are bicyclists. So about 60 to 70% of them in that category. So it's a vulnerable population that we are dealing with, and they need to get to a hospital soon, and they are anyway getting to the hospital in an urban setting. Problem comes in delayed care. So I have this young boy who got injured into a crash with a major artery injury to his leg and an injury to his pelvis, and he lands up in a major trauma center, so-called trauma center. They told there is no bed vacant. Then he goes to another center, again no bed vacant, then he goes to a corporate hospital. And before this, he was being shifted from a rural area. So before this, he had gone to the local center and then gone to another center which was a bigger hospital in the region, in that district. They said, we can't handle this, we can't handle this. Comes all the way to Delhi, goes to a facility, again we have no beds. Then goes to a corporate sector, makes an assessment of 1,500,000 rupees as the expense for treating that patient, and they can't afford it, and then they go to another facility, they again unaffordable, they come to me, and by then it's several hours down the line, his limb is becoming gangrenous, he is going down the drain, and the patient gets about 8 to 10-year-old boy. And 10-year-old boy, he was in 5th class, yes, he was a 10-year-old boy, he was in 5th class. He comes in, we deal with whatever is possible, he gets a bad infection. It was a rural road traffic injury, he gets a bad infection, and eventually he dies because of septicemia. So delay, how do you deal with delay? That is a problem, that is a challenge. Now if this patient could get good care in that area, in that district, instead of coming all the way several hours down the line to Delhi, probably his life would have saved. He died of infection which was uncontrollable, some bugs which we couldn't, we gave every antibiotic under the sun we could give him, but we couldn't save him. So that's something which is really distressing to me, a clinician. So how do we overcome that? If you build capacity at the peripheral levels, and what is the capacity? Merely having surgeons won't work. You don't get good surgeons off the shelf like you're buying cornflakes. No, you don't. Or you're buying any of those disposables that are there. You can't get them. They need to be trained. They need to spend years in training, particularly dealing with some of these complex traumas. So how do you build capacity? You have to plan. So short-term plan, long-term plan. So the first thing that you need to have is peripheral capacity. Every district hospital must have a trauma team. A trauma team is required. So what do you mean by a trauma team? So you have to designate If there is a serious injury patient coming to the hospital, you have to designate, there has to be a team which is activated, and the team must have a general surgeon, it must have an orthopedic surgeon, it must have an anesthesiologist, must have trauma nurse, must have all these would be there, but they need to be trained to take care of a difficult injured patient. And unless you do that training and unless you do that capacity building, you will continue to have your patients dying or becoming maimed from crashes like this. But what happens? People are building only ambulances without looking at the trauma facility, trauma team concept. So, building ambulances alone will not work. Building ambulances only shift the death from the roadside to the bedside. We are not doing that. We don't want that. We want them to be saved. To be saved, you have to look at, get them quickly to the hospital. It doesn't have to be highly equipped ambulance, even a simple vehicle that can carry the patient safely. So, how do you shift patients? How do you extricate patients? Those are minimum training that can save these lives and get them to the, it doesn't have to be advanced life support in most cases. That's a very critical, maybe inter-hospital transfer or something. Most cases a simple facility, getting to a hospital, that's critical. Once you reach the hospital, then you have to make sure that the patient gets everything that he needs, and what that is possible only in a trained, capacity built hospital with the trauma team in place, with the equipment required for care. Again, the corporatization of healthcare has made healthcare very expensive. So, you have millions of rupees being generated from sale of petrol, sale of motor cars, sale of, so they are causing all this injury. So, we have as a society come to accept death as a cost of mobility. I do not think we accept for anything else. Why should we accept death as a cost of mobility? It is too high a price for families. We do not want that. So, we want to get away from this death from. So, we have to think in terms of prevention, like our friends like in TRIP Center, Dr. Geetam and Girish and Rahul, they are all working in preventing this thing from happening. Why should you have this death? So, having a vision that no serious injury or death from the road traffic injury has to also part of our vision. Unless we have that. And one important thing, we will have delays, and while we are waiting for this whole thing to happen, this delay can still be managed well with whatever is available, and there is one drug which is now recommended for all trauma victims who have trauma, and within 3 hours if you give tranexamic acid, it is shown in seriously injured patient, it reduces mortality by a third, which means if there are 100 seriously injured patients, 30 would be saved. That is a huge number, it is a very cheap drug. Earlier it was recommended to be given intravenously, today even intramuscular is working. So, in UK for example, every ambulance is supposed to carry tranexamic acid. So, even the peripheral most one in the primary healthcare center can give a tranexamic acid to a trauma victim, give him first aid, splintage, all that you need in first aid is splintage, control of hemorrhage, and shift him to the district hospital which has the capacity to take care of the trauma victim.
Now, just hearing this talk as a mother was so emotional for me, and you know, I think if we could get even this information about tranexamic acid out, you know, I think that would save how many lives. What would you like as an outcome of this conference?
There are so many facets of injury being discussed, not just road traffic injuries. So, one important message that I always talk about in our workshop that we do in IIT also, we blame the victim. We blame the victim for having had the injury because he was negligent, because he was careless, because he did something wrong. We do not blame the product, and we do not blame the environment which was created by the society at large. So, instead of looking at behavior change in injury reduction, if this conference can get the message across, can we do primary prevention by changing the environment in which the person is living and changing the product design that is there, then it will be. So, in case of roads, it will be design of the roads, design reducing speeds. The number one denominator for death is speed. So, if we can reduce speed in urban areas, in village areas, that is the best way to So I would want that as the take of primary prevention. Trauma care comes much later, but that's also an important aspect. Once we have failed there, only then trauma care comes in.
Like you said, I mean, death being the price we pay for mobility, I mean, there is no reason.
We don't accept for anything else.
When there are solutions, there's so many solutions, and we absolutely cannot accept something like this. Thank you so much. Really appreciate your talk, and look forward to seeing you in other sessions in this conference.
Thank you. Thank you. All the best.